The broadcast is now starting. All attendees are in listen-only mode.
Hello, everybody, and thank you for joining us today. I'd like to welcome you to our discussion on the calendar year 2021 Home Health Final PPS Rule. Before we begin, I just want to go over a few items so you know how to participate in today's event. You're listening into the webinar using your computer speaker system by default. If you would prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. The handout for today's webinar can be obtained by expanding the Handouts pane in the control panel and clicking the file to open or download. We will be taking questions during the webinar, and we've allotted some time at the end to answer as many as we can. You could submit your questions throughout the session by typing into the questions pane of the control pane. Before I introduce today's presenter, I'd like to tell you a little bit more about HealthRev Partners. We're a team of individuals passionate about securing the success of home health and hospice agencies across the nation. Over the past several years, we've seen a growing need for a more modern, tech-driven approach to revenue cycle management. So, as a result, we offer coding and billing services that ensure timely, accurate claim submissions backed by cutting-edge technology, exceptional service, reliability, and transparency. Make sure you stick around until the end of today's webinar. We've got a special offer just for webinar attendees, so you will not want to miss it. All right, let's get started. I'd like to introduce to you today's presenter. John Reisinger is the Principal of Innovative Financial Solutions for Home Health and is a CPA that specializes exclusively in the home health industry. Working in home health since 1992, John has held various roles, including Medicare auditor, as well as VP of reimbursement for a large multi-state home health organization. He established his consulting company back in 2008, and since then, he's been leading the charge to bring back financial fundamentals to home health. John has also licensed the industry's first patient budgeting tool called the Home Health Care Resource Planner. It's a web-based app that can enhance your profit potential while enabling you to provide top-of-the-line care. As a strong advocate for the home health industry and a nationally recognized speaker on a wide variety of financial topics, we've asked John to join us today to discuss the various updates included in the final rule and their projected impact on your organization. So I'd like to turn over to John.
Thank you, Megan, and hello to everybody today, and thank you for joining our presentation. So we'll get right into it. Okay, so this is about the 2021 Home Health PPS Final Rule. So the primary areas which we're going to discuss today are going to be the home health PPS changes. This is the big area. That's going to include the case mix weights, the 30-day payment rates, changes with the rule add-on, the LUPA thresholds, the LUPA payment rates, and no pay wraps. We're also going to talk about the outlier provision because I feel that this is a grossly misunderstood provision of the home health reimbursement calculation, and I want to try and help more people understand the impact this provision has on their profits, their Medicare cash flow, and their total cash flow. We're also going to talk about a little bit about the changes with a home infusion therapy and telecommunication and remote patient monitoring. Other areas identified in the final rule, but not having any significant or any changes at all, include the LUPA add-on payments, but we will talk a little bit about that later on, HHQRP, OASIS, and home health value-based performance reporting under the COVID-19 public health emergency. So CMS expects the changes per this rule to impact home health spending, and they expect that impact to be, we can see over here in the box, this is carved right out of the final rule, and they're projecting that impact to be an increase of $390 million to home health spending in 2021 as compared to 2020. And that equates to a 1.9% increase in home health spending. However, this is actually down a fair amount from what was originally proposed. They originally proposed the impact was going to be 540 million with a 2.6% increase in home health spending. But before we get into some specifics of this rule, I want to talk about the rule-making process. Okay, this is something that's very near and dear to me, and I think that the industry really needs to understand more about this to become actively involved. This is a significant area that the industry and associations squander, and I use that word specifically, okay, we have squandered each and every year since the inception of PPS back in 2000. The rulemaking process is how we have a chance to impact the rules that are proposed by CMS or anybody else each year. Any rule that's going to have a significant, what's deemed a significant financial impact, which is almost all rules towards us, we have a chance to submit comments to impact those rules every year. So we do this, we participate in the rulemaking process by submitting comments on the various issues and aspects identified in any given proposed rule. But, and I've been saying this for years, and people still do this, organizations still promote this. You don't do this by copying and pasting the same comments multiple times. As an ex-auditor, a Medicare auditor, and just general auditor in general, copying and pasting something like this, to me, actually detracts from the original comments. Okay, if people aren't going to take the time to reword the same comments, that they can change the wording, they can say the same thing, but just change the wording, so it's not obviously that it's just a copy and paste, then the reviewers of this are going to really discount the volume that copying and pasting creates. This year, for 2021, there were 166 comments submitted for the proposed rule, on behalf of the home health industry. So if we attribute one comment's not just one issue. I mean, a lot of times it is just one issue, but a lot of times it's, it could be 15, 20 pages worth of comments. But if we attribute one comment to one agency in the industry, those 166 comments equate to approximately 1.3% of the agencies in the industry. And oh, by the way, I think there were only about 20, 25 home health agencies that actually submitted comments. The rest of it was from individuals, from associations, consultants, like I submitted comments, National Association for Home Care and Hospice submitted comments, so a few of the bigger organizations, they submitted comments. But the vast majority of comments were not from home health agencies, which to me, I think is just ludicrous, okay, because it's your livelihood. You have a chance to impact your livelihood. Now, of those 166 comments, there were 153 which CMS made available for review. So if we went to where the docket is for the proposed and final rule, we would see something that would look like this. And over there in the bottom right, you could see that it says 166 comments received. And anyone can actually go in and review these comments. Just like anybody can submit comments, anybody can go in and review the comments and see who all submitted comments to advocate for our industry, because this is one of the biggest ways that anyone can advocate for our industry. For example, see the following. Okay, so here I just snipped the page where I was going in and reviewing the various comments in here. And we can see in red up at the top of that, it says 153 results. Well, those were the comments. Of the 166 comments submitted, there were 153 that we're actually able to review. Not sure what was up with the other 13. Some comments were good and thorough. I like to think mine were. The National Association of Home Care and Hospice, theirs are very good every year. Some of the bigger chain organizations like LHC and Medicis, they have some really good comments. Some other associations, a couple of state associations, they had some good comments, but many, unfortunately, were not all that great. Some were even questionable as to how is this germane to the proposed rule. and 55 of the 153 available comments for review were of the copy and paste approach. Physical therapy group, organization, something, put together a template letter, and there were, there was the original letter and there were 54 copies of it. Basically an exact copy. There was just an intro paragraph that was a little bit different, but the whole body of the letter was exactly the same. So to me, that detracts from the value of the comment that was being made. And if we take away those 55 comments, take away 54 of them, we're actually under 100 comments for the entire industry, which is extremely disappointing when there's, approximately 12,000 home health agencies out there, let alone all the associations, vendors, consultants, everybody that works in the industry. We had a real opportunity to push for more regarding telehealth in particular, okay? Trying to get certain telehealth visits, not all telehealth visits, but get some telehealth visits to become allowable, chargeable visits that would count against the LUPA, okay? But there really wasn't I heard hundreds and hundreds of people clamoring about that during the, in between the period of the proposed and final rule, talking about, oh, we want this, but there wasn't the push with the comment submission. So this was a lost opportunity. So the drop from the proposed rule, now I'm talking about that the proposed rule originally was, saying it was going to be 540 million and 2.9%, to the final rule saying 390 million increase in home health spending, 1.9%. The drop from the proposed rule was primarily due to the change in the updated inflation through the period reviewed by CMS for the proposed rule, or for the final rule, as compared to the period of time they looked at for the proposed rule. So the data used in this final rule was approximately 6 months later. They had 6 months more current information than the data used in the proposed rule. So now I want to get into more of the significant issues, the changes with this final rule. Okay, so we're going to discuss the following. We're going to talk about the no changes to the case mix weight and LUPA thresholds, the 30-day payment rate, the LUPA payment rates, a change that's happening this year with the county designation, 131 county designations, and we'll see what that means shortly. Talk about the changes that are happening with the rule add-on and how that is slowly coming to an end unless there is legislative change. The change over to the no pay wrap. So this about the common, the case mix weights in the LUPA thresholds. Now, everybody should know that for every service area that you operate in, there are 432 unique case mix weights. Each one has a payment rate associated with it, with a specific HIPS code. And then there's a range of 2 to 6 as to what those LUPA thresholds could be. So CMS is not proposing any changes to the case mix weights or the LUPA thresholds for 2021. And this is somewhat unexpected, but their rationale, which makes sense, is that they just didn't have enough information to make changes to the case mix weight because there was a question of the volume of the information that they had, and because of what happened with the pandemic, that really messed some things up. It was somewhat unexpected though, because CMS had been regularly changing the case mix weights each and every year for a number of years now. So, but with them holding this stuff constant from 2020 to 2021, this makes projecting what the likely impact to your Medicare revenues will be for 2021. It makes it much easier. Okay, and this is something that all agencies should be doing every single year. It's calculating what the impact is going to be to your agency for the proposed rule. Because if you do it from the proposed rule, then you basically have 5-6 months to prepare for that change. Sometimes you don't need that much time because the projection is not bad at all, but other times it can be surprisingly bad. And we'll see that shortly. And there is a misconception regarding the change in home health spending, which again, for 2021 is projected to be 1.9%. But this change is for total home health spending, not, I repeat, not what the change will be for any given agency. As many that talk about this rule and have since the beginning of PPS seem to indicate. What CMS is identifying is what the change in home health spending is going to be, not what the change is going to be for any or all agencies in the industry. That's what the average change is. For example, one service area, one CBSA, will see an increase in their 2021 PDGM payment rates. That means for all 432 payment rates for this one service area, every single one of them will increase 14.8%. Another CBSA, another service area, will see a decrease in the PDGM payment rates of 6.3% for all 432 payment rates for that service area. And the most frequent change will be an increase of 1%, not the 1.9% change identified by CMS that most people that talk about the final rule, proposed rule, final rule reference is what you can expect to be the impact of your Medicare revenues. This year, the change to your payment rates will be the same for all 432 payment rates. Usually each payment rate changes at its own unique rate because of other changes that usually occur. But those changes that usually occur are not occurring this year. So it's keeping things constant. So if you know what the change in the payment rate is in any given service area for one HIPS code, one case mix weight, you know what the percent change is for all 432. So what's the impact to an agency if that agency was expecting a 1.9% increase in revenue, Medicare revenue, but actually realizes an increase in their PDGM rates of 14.8%? Well, life's pretty easy for them, right? Well, how about the agency that's expecting a 1.9% increase in their payment rates, but actually is going to have a decrease of 6.3% in their payment rates for 2021? Their life's going to be a bit more challenging. That's an 8.2% spread for the negative, because it's dropping from a plus 1.9 to a minus 6.3. That's why I recommend having the projected change in your PPS rates calculated every proposed and final rule change to avoid surprises, especially bad surprises. Okay, the agency that's getting the increase of 14.8% and they didn't do the calculation, well, they're still going to have a pretty easy time of it. But the agency that's going to have a 6.3% reduction in their payment rates would have had a lot more time to prepare if they would have had this done. And this is a basic business financial fundamental that all home health agencies should be employing every single year. Now I want to talk about the 30-day payment rate. First off, I want everybody to keep in mind, right now sequestration has been put on hold. Currently, unless there's a change, sequestration returns in January 1st, 2021. And everything we'll see is pre-sequestration, as that's how it's presented in the Federal Register. The 2021 home health payment percent update is it nets out to 2%. And that's made up of a 2.3% market basket update, that's our inflation update, minus a 0.3% multi-factor production adjustment, sorry about that, which nets out to the 2%. They came up with that MPA, multi-factor production adjustment, about 3 years ago, I think. So this is projected to increase home health spending by $410 million. That's a 2% increase. Now, note, this is different than the $390 million that CMS is projecting, the 1.9% that CMS is projecting, because those numbers that CMS is projecting is for the entirety, inclusive of all changes in this final rule. This here that we're looking at the moment is only looking at the change associated with our home health payment rate update because of inflation. So this is one part that goes into that 1.9%. And again, keep in mind, sequestration is set at 2%. So the 1.9% increase that they give us, well, they take it back with the other hand in 2021. So following are the 30-day payment rates. Okay, the first one is for agencies submitting the required quality data. And the required quality data is primarily the OASIS and HCAHPS. And almost all agencies comply with that, but there are a few that don't, whether they're new agencies or they just haven't really gotten their act together yet. So we basically start over on the left-hand side of that table on 1864.03. That's what the 30-day rate is right now. We do the updates in columns 2 and 3, and we come up with the payment rate for 2021, which is the 1901.12. And then we look at what that is, 30-day payment rate is for agencies not submitting the required quality data, and their rate is 1863.84, which is actually less than the 30-day rate that currently exists. And these rates are what are used to calculate all 432 of your PDGM payments, PPS payment rates for each service area you operate in. Sorry about that. Excuse me for a second.
Call from toll-free call.
I apologize for that. I forgot to put my do not disturb on. So remember, for 2021, the percent change in any one rate from 2020 to 2021 for any service area will be the same percent change for all 432 payment rates for that service area. It doesn't usually work like this, but it does this year. The LUPA payment rates. The LUPA payment rates are the per visit rates that we're very familiar with, and we're reimbursed for any LUPA payment periods throughout the course of the year. Additionally, the LUPA rates are used by CMS to calculate an agency's imputed cost in the outlier calculation, as an agency's actual costs are ignored. They're not considered. And LUPA rates are increasing for 2021. So following are those LUPA rates. Over on the left, we're going to see what those rates are for agencies submitting the required quality data. Over on the right, we have those rates for agencies not submitting the required quality data. And you can see there's about a 2% difference there between the two. The not submitting, of course, being lower. The LUPA add-on payment. As previously noted, the LUPA add-on payments are remaining the same for 2021. These are the additional payments made based on the first visit of a LUPA situation to account for the higher costs due to the OASIS and other administrative functions. Now, we have to keep in mind that the LUPA add-on payment is only applicable for the first 30-day period in a series of contiguous 30-day periods. And it has to be, it's the first 30-day period in an admission of care where the patient had been off of home health rolls for at least over 60 days, for at least 61 days prior to the start of care, start of this 30-day period. So following are the LUPA add-on payments for 2021. So skilled nursing, it's 1.8451, PT is 1.67, and speech is 1.6266. So what they do is you calculate out what your LUPA per visit rate is for that first discipline that you do in that 30-day period, and then you get to multiply that rate by this factor, depending on the discipline that does that first visit, to get what your LUPA add-on payment, what the total payment rate is for that first visit. This factor is multiplied, again, as I said, against the first LUPA visit. Now I want to talk about the change in the 131 county designations. The OMB has created new delineations for 131 counties in the Medicare program. OMB is the Management and Budget, Organization of Management. Oh, geez. Sorry, having a little brain freeze there, but it's the budgeting organization. So of this, it's broken down into several categories. There's 34 counties or their equivalents. Could be parishes, could be commonwealths, depending on what state they're in. But 34 counties or equivalents changing from urban to rural. Okay, now chances are every one of these agencies, every one of these service areas, I should say, is going to have a significant drop in their case mix weight. However, these counties, even though they're switching over to urban, will not be eligible for any rural add-on payment. There are 47 counties changing from rural to urban. Well, those counties are probably going to have a nice little increase in their wage index. 31 urban counties move into a different urban CBSA, and 19 urban counties move into a new or modified CBSA. And then some of those counties are going to have wage indexes that go up. Some of them are going to have wage indexes that go down. Now, CMS has stated there will be a one-year transition limiting the reduction to 5% that a county's wage index can decline in 2021 because of this. But there's no such cap in 2022, and there's no restriction on the amount that a county's wage index can increase, generally speaking, when they go from a rural setting to an urban setting. But there are some of these counties that are going from an urban to a rural that they can have a wage index drop 12, 15 points. So this year in 2021, that county wage index can only drop 5 percentage points, but there's no limit to how much it could drop in the subsequent year. The rural add-on, it is changing as proposed and finalized back in 2018, started in 2019, and this is the table that we have. Now we have 3 different county, you look at the left, there's 3 different county designations. That's what category is. We have high utilization. High utilization are the most highly populated counties. Okay, low population density is the exact opposite, the least populated counties. And all other sort of fits in the middle, in between those two. Fewer rural counties will be eligible to receive a rural add-on payment in 2021. Of the approximately 2,000 rural counties, 510 are designated as high utilization counties, so we can see high utilization in the first row, and will not receive a rural add-on payment for calendar year 2021. So if we look up there at high utilization, go over to calendar year 2021, we see none for the rural add-on. So the rural add-on rates are being reduced, and they have been since this was passed back in 2018. So low population density, the row in the middle, okay, those counties are having a rural add-on that's decreasing from 3% right now in 2020 to 2% in 2021, and all other counties are dropping from 2% to 1%. So this is, again, this is projected to reduce home health spending by 20 million, you know, a 1% decrease. And as legislated, calendar year 2022 will be the last year of the rural add-on, and only low population density counties will be getting a rural add-on, which will be capped at 1%. So unless there's new legislation in between now and 2022, the rural add-on disappears. It sunsets in 2022. At the end of 2022. The wrap becomes the no pay wrap for 2021. So there's big changes here. Okay, first, there will be no payment associated with the wrap. And personally, I think that's where the biggest issue that any agencies that have a problem with this is where they're going to have it. Because the 20% that they currently receive as a wrap payment disappears. The wrap will change its name to a no-pay wrap. And agencies will be required to submit no-pay wraps for all 30-day pay periods beginning on after January 1, 2021. And in 2022, the no-pay wraps changed their names over to an NOA for all 30-day periods. And the NOA is a notice of admission. It's similar to the hospice NOE, notice of election. So to minimize the documentation burden going forward, since there's no payment associated with the no pay wrap, CMS has lessened the documentation requirements for this. And this is taken right out of the final rule. So there's 2 points that we have to settle, we have to comply with before we can submit the no pay wrap. Okay, we have to have the appropriate physician's written or verbal order that sets out the services required for the initial visit, that it has been received at our offices and documented as required. And number 2, the initial visit within that 60-day certification period, within that first 30-day period, pay period, within that 60-day certification period, has been made, and the patient has been admitted to home care. So as soon as those 2 points have been crossed, you can submit your no pay wrap. You don't have to calculate out what the HIPS code is. Okay, so submitting the no pay wrap should be a no-brainer. It should not be hard at all. The following was extracted from Medicare Learning Network transmittal. So, and down here is the link to that transmittal. So we have 2 paragraphs here. The first paragraph is talking about that starting next year, starting in 2021, there's going to be a financial penalty for all late, non-timely submitted no pay wraps. Okay, and the second period is talking about how you calculate out what that penalty is going to be. Basically, the penalty is going to be based on the following calculation. It's going to take what your HIPS payment rate is times the numerator of the factor is going to be the number, the day number, somewhere between 1 and 30 that you submit the no pay wrap. The denominator is always going to be 30, which coincides with the time frame for the 30-day billing period. Okay. So all no pay wraps and NOAs must be submitted within 5 calendar days from the start of care, or financial penalties will apply. For example, a wrap submitted on day 6 will incur a 20% penalty. Day 6 is number 6 out of 30, so that's the numerator. The denominator is always 30. So 6 over 30 is 20%. A wrap submitted on day 10, 33.33%, 10 over 30. A wrap submitted on after day 30, 100% penalty would apply. You would receive no payment for those services. And LUPAs are impacted as well by late submission, meaning that if you have a LUPA situation, any visits that you did prior to the submission of the late no pay wrap, those visits will not be paid. So the point is, submit your no pay wraps timely. That is in days 1 through 5. The home infusion therapy benefit. This update implements Medicare enrollment policies for qualified home infusion therapy suppliers, and home health agencies can be that. It updates the 2021 home infusion therapy services payment rates using the 2021 physician's fee schedule amounts, and excludes home infusion therapy services from the home health services as required by law. It's basically memorializing it, meaning it's not considered part of the bundled services attributable to home health. Licensed agencies can perform home infusion therapies or can contract with outside suppliers, and payment will be dictated by the 2021 physician fee schedule. The outlier provision. Although the outlier provision and calculations are remaining the same for 2021, there's an aspect of this provision I'd like to briefly discuss. That's the loss sharing ratio, and I'm going to point out a few things first. Okay, the loss sharing ratio will remain at 0.8. Okay, this, in other terms, is the outlier payment. That's another name for your outlier payment, the loss sharing. And that means that once your loss exceeds a certain point, Medicare will cover 80% of the loss in excess of that threshold. The outlier fixed dollar loss is set to remain at 0.56. Well, this is that threshold, the fixed dollar loss. This is the amount of loss costs in excess of revenue that you have to incur before any loss sharing by Medicare kicks in. And the agency-specific 10% cap in Medicare payments will continue, meaning that no agency can receive more than 10% of its total Medicare payments in the form of outlier payments. Additionally, the funding provision of the outlier will remain the same as it has been since calendar year 2011. And it's this last point that I want to talk a little bit more about. So how the funding provision works is CMS puts all home health monies into a bucket, okay? And then that's 100% of home health spending. And from that bucket, they take 5% out and put it into a separate bucket to fund the outlier provision. So our regular episodic payments are only based on 95% of what's supposed to be coming to home health. And then the outlier funds are over in another bucket to be paid out in a different manner. And then CMS has also set up a cap of 2.5% of total home health payments for outlier payments for any given year. Now think about that. They took 5% out to fund outlier payments, but there's a cap of 2.5% in outlier payments for a given year. So that creates a discrepancy. So 1/2 of the amounts withheld to fund the outlier provision are removed from home health spending and are not paid back to the industry in any shape or form. This is effectively a 2.5% cut to the industry reimbursement rates. Did you know that? And this has existed since calendar year 2011. This was part of the PPACA, the Patient Protection Affordable Care Act. Okay. Each year, this amounts to approximately, and it could be plus a little bit, minus a little bit, but this is a pretty good round number to work with each year, $450 million in Medicare funds that have been withheld from the industry. So this is 11th year, 2021 will be the 11th year of this discrepancy. Telecommunications. In this final rule, CMS permanently finalizes certain changes regarding telecommunication and remote patient monitoring, changes that mostly took place because of what was happening with COVID-19. However, we cannot substitute telehealth visits for home health visits as ordered per the plan of care. And remember, this was an area that I was really hoping that we were going to get widespread comment submission from the industry. This is where one of the places where we really dropped the ball as an industry. We must include any usage on the plan in the plan of care. If you're going to use telehealth, you got to indicate on the plan of care that you're going to use telehealth with this patient, and you must describe how it's going to be used regarding patient-specific needs. But CMS does not expect to see how it will help achieve the goals being described, outlined in the plan of care. You don't have to put all that into the plan of care, but they do expect to see how such services will be used to help achieve the goals outlined in the plan of care throughout the medical record when such technology is used. So you need to make sure that your medical record is supporting what it is that you say that you're going to do and show how it is benefiting the patient. And they are allowing a broader use of telecommunications technology to be considered allowable administrative cost on the home health cost report. Okay, now this was happening whether or not the public health emergency happened. This was something that was already happening. This just made it final. But this is a good thing though, because historically, any telehealth costs were deemed non-allowable costs. So that concludes our detailed look at the 2021 final rule. Okay, we've discussed the following area: the changes to the wage index, the PPS payment updates, the rule add-on payments, the issue with outliers. Even though there's no changes, I wanted to try and help identify that a little bit more for everybody. RAP submission changes for 2021, because that's a big one, but the biggest part of it is the two of them. It's the loss of the 20%, and the financial penalties for late submission of RAPs, but because of the significantly reduced documentation requirements to submit the no-pay RAP, there really is no excuse for submitting a late no-pay RAP. And the use of technology under the Medicare home health benefit. And we started with a discussion on the importance of increased industry participation in the rule-making process. That we as an industry had another disappointing year of industry participation in the rule-making process, because both the quantity and the quality of the comments submitted do make a difference. And this was one of those years that we really had a hot button topic that we really could have jumped on, that we really dropped the ball. And that was trying to push for certain telehealth visits to be treated as allowable chargeable visits, because docs get to do it, outpatient therapy clinics get to do it. Okay, so if outpatient therapy clinics can do it and our therapists can do the same thing, why can't those visits be considered allowable chargeable visits also? Okay, and that we lost a tremendous opportunity to push the expanded use of home health, as I just described, and to push for telehealth visits to be considered allowable and chargeable visits under the home health benefit. So that concludes our presentation. I want to thank you for your time. And now we do have some time, so I'll pass it back to Megan for our Q&A. Here's my contact information. You have it in the handout. So if you have any questions or anything regarding this presentation, I'll try to help you out. I'm not going to charge you for something like that. So give me a call, and if you need any financial help, I'm there for that too. So I will pass it back to Megan.
Thanks, John. We've got some questions for you. First question, can you please explain the outliers again?
Okay. The outlier is an additional incremental payment that CMS, that Medicare makes for certain episodes when you incur a significant amount of cost over what we're being paid to care for. Historically, diabetic patients, daily patients are big outlier patients. Wound care patients are quite often, although in the outlier calculation, the cost of medical supplies, and that would include wound vac, are completely ignored. So that sort of depresses that number a little bit. But when our costs, and it's not our costs, remember, it's the imputed costs. It's where they take our actual visits that we do, multiply it against the per visit rates for the service area that we're in. If that cost exceeds the episodic payment rate by 56%, then Outlier will start sharing in the loss, the imputed loss that's in excess of 56% greater than what the episodic payment rate is. And they will pay 80% of the amount in excess of that 56%. That 56% is the fixed dollar loss. That's the amount that you have to lose before the loss sharing ratio, the outlier payment, kicks in. They're generally speaking, they're going to be associated with high volume visit patient encounters.
All right, got another outliers question for you. So the fact that we do receive outlier payments over the course of the year is not necessarily indicative that this aspect is actually beneficial for our agency?
Oh no, oh no, and it is not. And this is one of the ambiguities that create the false impression in the industry. Because almost everybody in the industry that I've ever talked with over the years has historically felt that the outlier provision is good for them because they get outlier payments. Okay, but what they don't realize is all their episodic payments are reduced 5% to fund the outlier provision. So what you have to determine is how much did you lose because of the 5% reduction in the payments that you did receive compared to what did you receive in outlier payments. And it's very common for agencies to have the amount that was withheld to fund the outlier provision to be 5, 10, 25 times greater than what they received in outlier payments. So you can compare that because you know on the cost report, worksheet D, lines 12.01 through 12.04, I believe, and I'm doing this off the top of my head, I'm sorry if I'm not 100% correct. These identify what your episodic payments are. So you sum those numbers up, put them off to the side. And underneath that, at 12.10 to 12.14, I think it is, these are your outlier payments. So you sum those up and put them off to the side. And then you go back to your original payments, your total episodic payments. Take that sum and divide it by 0.95. That's going to give you a pretty close indication of what the total payments would have been if the 5% hadn't been withheld. Then you compare that amount to what they actually paid you in your total episodic payments, and that's the amount that was withheld. Okay? You compare that amount to the outlier payments that you received, and that's going to tell you whether you're to the good or to the bad. And in my experience, close to 99% of all agencies I've ever worked with, they've been to the bad, and some of them have been to the bad to the tune of hundreds of thousands of dollars a year.
And here's a follow-up question. Oh, sorry.
Let me go on a little bit, Megan.
Sure.
So what I have always done when I'm submitting my comments during the rulemaking process, one of my standard comments is get rid of the outlier provision. Just eliminate it. The secretary has the option of whether or not to implement an outlier provision in home health. I'd say just get rid of it, which is what I recommend everybody do, assuming that that's going to be the case. Okay.
Here's a question. It says, so does that mean that an agency will lose money with daily wound care?
You're doing daily anything, you're going to lose money. Doesn't have to be wound care, doesn't matter what it is, you're going to lose money. And the problem is with daily, like a daily diabetic patient, okay, all your costs are more or less going to be based on your skilled nursing, maybe physical therapy or aid visits. With wound care, it's going to be exacerbated because all your wound supplies are going to be ignored. You're not, the outlier payment is not going to give you anything for those. No medical supplies whatsoever. It's all based on visits. So yes, simple answer is yes. It means you will lose money, even after the outlier payment.
All right, next question. Not sure if you can answer this, but I'm going to ask you anyway. Are the requirements for the no-pay wraps the same for Medicare demand billing for denials required in order to bill Medicaid?
I couldn't answer that question 100% certainty, but I would be up in the 90th percentile saying I would think yes. That what Medicare requires, Medicaid knows. And so once we comply with what Medicare has done and then we show that it's rejected, then we can take that and include that with what we submit to Medicaid.
All right, another question for you, John. This is about home infusion. For home infusion, do you submit via Medicare Part A or Medicare Part B? And if Part B, do you need to become a Part B provider?
Well, I don't do billing. I mean, most financial consultants you hear about out there, they generally don't do financial consulting. They do billing, coding, that kind of thing. I'm the opposite. I do financial consulting, so I don't do billing, coding. But I am 99% sure that that is going to be Part B. It's going to be subject to deductible and co-insurance.
All right, great. Let's switch over to wage index changes. If our agency operates in one of those counties that changed, for example, we went from urban to rural, does this change impact all the revenue that our agency earns?
Just the revenue that is earned in that county for the patients that you service in that county. If you have other service areas that you operate in that are part of a different CBSA or whatever, it's not going to impact them. It's only going to impact the revenue or the services you provide in that county. But if you're 100% of your services are in that county, then yes, it's going to be across the board for all revenue that you receive.
All right, sounds good. Got a question about wraps, John. In regards to that, it says the visit might not be made in the first 5 days, so the wrap goes, and then when the final is submitted, the first date doesn't match. Is this being accounted for, or do we have to cancel wraps to fix the date to match the final? Again, not sure if that's something you can answer or not.
Yeah, again, as someone that doesn't do billing, I can't say with 100% certainty that it's, how you would have to do it. But I can say with 100% certainty that you're not going to be subject to a penalty. You submitted your wrap timely, and if there's a disconnect between, the first visit and what the DD system is showing, you're going to need to correct. Somehow that's going to have to be corrected, but you're not going to get penalized if you have to cancel and resubmit, because you had originally submitted it timely.
Excellent. Let's talk about the payment update. You mentioned that there is a lack of financial fundamentals in home health. Well, what are they, and how can you help us?
Well, I mean, that's what I do as a financial consultant. Financial fundamentals, basic business fundamentals, financial fundamentals, a lot of these are germane to business, not specific to home health. These are just sound business practices. A lot of them are tweaked specific for home health. A basic one, less than half the agencies in this industry do an annual budget. That just blows my mind, okay? Less than half the agencies in this industry do an annual budget. But to make it even worse, I would say 80%, at least 80% of the agencies, the less than half that actually do a budget, their budget really provides them no value whatsoever during the budgeted year. They do a budget, it gets approved, they throw it in a drawer, and they don't pull it out until it's time to do next year's budget. A budget is supposed to be a tool to help you manage the budgeted year. Compare what you're actually doing to what you budgeted, and then identifying the variances and identifying why the variances are occurring. That's where the value's at. Okay, what I call monthly financial operational analysis. Again, I would say 80% of the industry doesn't do this. In my book, this is just a regular business approach. Every month when you close your books, you should be analyzing your financial and operational results, identifying key metrics, looking at the drivers of your business, and this basically dovetails right back into your budget, because when you're doing these monthly financial operational reviews, you see the trends of what's going on with your business. When something out of the ordinary crops up, okay, it helps you identify how to address this. It may not give you the exact answer. A lot of times it does, okay? But sometimes it doesn't give you the exact answer of what you need to do, but it points you in the direction of how to identify it. Because to me, it's amazing that I would bet that less than half of the agencies in the industry actually know right here, right now, at this moment, what their actual skilled nursing cost per visit is. And you need to know all your disciplines. They don't even know what their skilled nursing cost per visit is. Well, we have it in last year's cost report. last year's cost report was for a period that ended 11 and a half months ago. So teaching agencies how to do this. Agencies should be budgeting like I have for the resource planner. They should be budgeting, doing a projection. And I'm not trying to make you financial managers of care. That's not what I'm trying to do. You should be projecting out what we think the financial implications are going to be of the resources that we plan to provide for every episode of care, for every patient encounter. Okay, this is one of the big reasons why so many agencies have such a hard time when Medicare is still such a generous payer. Still such a generous payer. I mean, the industry average profit margin in Medicare, according to MedPAC, I think it's around 17%. And that's average. You know, so when things get a little tight, you know, the agencies that are averaging below that are going to have a much harder time of it. How many agencies actually know what their days of receivables are? This is another one. This is money that's sitting on the table, not doing you any good. This is your money, okay? And this is what Health Rev Partners can help you with. Okay, I can help indicate it, but if they can help you with your billing, coding, that kind of process to speed things up, you know, that's all the better. Another thing that people don't look at, what's your days of accounts payable? That's just as important because these are liabilities that you have, debts that you have. I mean, and this is just, you know, we're just talking the tip of the iceberg here. So, and you can go to my website and you can look some of the things that I talk about with this. But yeah, so in my financial, yeah, well, anyhow, I'll just leave it at that. So.
Thanks, John. We've got just a few minutes left, so I'm going to throw one more question at you, and then we will wrap it up. John, if you submit a no-pay wrap within the 5-day expectation, when can you expect to receive the payment?
Well, when you submit a no-pay wrap, there is no payment associated. You will not receive payment for that 30-day period until you submit the final claim for that 30-day period. So you submit your no-pay wrap on day 5. No money is going to be transacted. Okay. The 30-day period ends on day 30. Let's say you submit your final claim on day 35. Assuming it's a clean claim, you know, and you're sending it into Medicare. Medicare is a prompt payer, a good payer. You're probably looking somewhere between, you know, day 30. Let's see, you sent it on 35, probably like day 38 to day 40. You know, 7 to 10 days after the end of that 30-day period. Assuming that it takes you 5 days, let alone just to get the final claim out. Of course, the earlier that you can get that final claim out, the better. You know, and this is a big thing for agencies to help them with their cash flow. Because as we go to this no-pay wrap, that's going to negatively impact your cash flow. Now, it's only 20% that you're losing, but you are losing it. And it makes it all the more imperative that you stay on top of your days of receivables. You don't want that number getting too big because that's money that could be helping you out when times are tough. Back to you, Megan.
Thank you, John. Well, I really appreciate you joining us today, and we appreciate all of you joining. You've given us a lot of great insight into the final rule and just how to prepare for 2021. So, as promised, we have an exclusive offer for today's webinar attendees. We know there's a lot going on for agencies this time of year, and really even more so as we continue to battle the COVID crisis. So we want to help you with your continued growth into 2021. And by doing so, we'd like to offer the reduced pricing that you see on your screen for our OASIS 45 review services, our Coding Plus service, billing service, and our billing recovery service. In addition to those reduced costs, we're going to waive all upfront costs, including implementation fees, and we'll give you a 60-day performance guarantee. This is a limited time offer, so if you're interested in this offer, just fill out the form that pops up as you log out of the webinar, and somebody will reach out to you soon. When you leave today's webinar, you will see the survey pop up, and we would appreciate that you give us your feedback. Again, you can use that survey to let us know if you'd like to connect with John for his services, or if you want to learn more about Health Rev Partners, RCM services, and the special offer for webinar attendees. You can also visit our website, call us, or email us to learn more. On behalf of Health Rev Partners and John Reisinger, we want to thank you for joining us today, and we hope that you have a great rest of your day.